There is a mistake I see many people over 60 make with the best of intentions. They believe they are protecting their heart. They are consistent with their medication. They watch their diet. Some even add a heart-healthy fruit they find at the grocery store every week. And yet beneath the surface, the disease process continues quietly. I am Dr. Javier Morales. I have practiced cardiology for more than 20 years, and there was a Tuesday afternoon appointment that forced me to rethink how I speak to my patients about cholesterol. My patient Alejandro Ruiz was 72 years old. For 10 years he had taken his statin every single evening. He never missed a dose. His LDL cholesterol was consistently in what we would call an excellent range. His total cholesterol looked controlled. On paper, he was the kind of patient we reassure, but when I reviewed his carotid ultrasound that afternoon, I noticed something that did not match the numbers. His arterial wall thickness had increased compared to prior studies, not dramatically, not an emergency, but clearly progressing. Alejandro looked at me and asked a simple question. If my numbers are good, why is this still happening? I paused before answering because the honest answer is not something we emphasize enough in clinic. Managing the number is not the same as stopping the process. That distinction matters more than most people realize, because cholesterol itself is only part of the story. The real danger is not just how much cholesterol you have circulating, it is what is happening to it inside your bloodstream and inside your arterial wall. Today I want to walk you through that process. Not to replace your medication, not to create fear, but to explain what might be missing from the conversation. When Alejandro asked me why his plaque was still progressing despite good numbers, the answer did not begin with total cholesterol. It began with chemistry. LDL cholesterol by itself is not a toxin. Your body uses it. It transports essential lipids to cells that need them. In its normal state, LDL is not designed to burrow into artery walls and cause damage. The real issue begins when LDL becomes oxidized. Oxidation is a chemical reaction that happens when particles are exposed to unstable molecules known as free radicals. You can think of it the way metal changes when exposed to oxygen and moisture. The metal itself is not the problem. What it turns into after oxidation is what weakens the structure. Inside the bloodstream, oxidative stress can alter LDL particles. Once altered, they behave differently. They are more reactive. They are more likely to penetrate the inner lining of the artery. And once inside, they trigger an inflammatory response. Here is where standard testing creates a blind spot. A typical lipid panel measures total LDL concentration. It does not measure how much of that LDL has been oxidized. Two patients can have the exact same LDL number. One may have relatively low oxidative stress, the other may have a high proportion of oxidized particles driving inflammation inside the arterial wall. On paper, they look identical. Biologically, they are not. In Alejandro's case, his LDL level had been reduced effectively by medication, but lowering the quantity of LDL does not automatically eliminate the oxidative environment that can modify the particles that remain. Aging itself increases oxidative stress, so do insulin resistance, chronic inflammation, smoking history, and metabolic dysfunction. When oxidative stress persists, the process continues quietly, even if the number improves. This is the distinction I wish more patients understood. Cholesterol management focuses heavily on quantity. Atherosclerosis progression is heavily influenced by quality and environment. If oxidation is the spark, the next question becomes even more important. What actually happens inside the artery wall once those altered particles arrive? Because that is where plaque truly begins. If oxidation is the spark, plaque formation is the fire that follows. When oxidized LDL particles slip through the inner lining of the artery, the body does not ignore them. The immune system reacts immediately. Specialized white blood cells called macrophages are sent to the site. Their job is protective. They are there to clean up damaged material and restore order. At first, this response is appropriate. The macrophage engulfs the oxidized LDL particle and attempts to break it down. If the exposure were temporary, the system might resolve quietly, But in a state of ongoing oxidative stress, the arrival of altered LDL is not a one-time event, it becomes continuous. More oxidized particles enter the vessel wall. More macrophages arrive. They consume more damaged lipids. Over time, these cells become overloaded. They fill with fatty debris they cannot efficiently process. Their appearance changes under the microscope. They begin to look swollen and foamy. These are called foam cells. Foam cells are not foreign invaders. They are your own immune cells overwhelmed by a persistent chemical environment. As they accumulate and eventually die within the arterial wall, they leave behind a lipid-rich core of cellular debris. Layer upon layer builds over time. This is the beginning of atherosclerotic plaque. It does not form in a single dramatic moment. It develops gradually, often silently over years. The artery compensates. Blood flow continues. There may be no symptoms at all. In Alejandro's case, his carotid artery did not suddenly narrow overnight. The thickening we observed on imaging represented years of microscopic activity inside the vessel wall. His body had been responding to oxidized particles long before the ultrasound ever detected a measurable change. This is why progression can occur even when someone feels well, and laboratory numbers appear reassuring. Plaque is not simply excess cholesterol sticking to a pipe. It is a chronic inflammatory process driven by repeated immune activation. And once plaque exists, the question becomes more complex, because plaque itself is not automatically fatal. Some plaques remain stable for decades, others become dangerous. The difference lies in what is happening within the structure of that plaque and in the environment surrounding it, which brings us to the next layer of the story, the part most patients never hear about and rarely see measured in routine care. Once plaque has formed, the story does not end there. In many patients, the process continues quietly because 3 additional protective systems begin to weaken with age and ongoing inflammation. The first involves HDL, often called good cholesterol. Most people are told that as long as their HDL number is reasonable, they have some protection. What is discussed less often is that HDL's benefit depends not only on how much of it is present, but on how well it functions. HDL carries enzymes that help neutralize oxidized lipids and support what we call reverse cholesterol transport, the process of moving excess cholesterol away from the artery wall and back toward the liver. As we age, the functional efficiency of these protective mechanisms can decline. Chronic inflammation, metabolic stress, and oxidative burden can impair HDL's ability to perform its cleanup role effectively. So a normal HDL number on a lab report does not always guarantee optimal protection at the vessel wall level. The second issue involves the structural stability of plaque. Plaque becomes dangerous not simply because it exists, but because of its potential to rupture. A stable plaque has a thick, fibrous cap covering its lipid core. An unstable plaque has a thinner, more fragile cap that is more prone to tearing. Inflammatory signaling within the arterial wall can activate enzymes known as matrix metalloproteinases. These enzymes participate in normal tissue remodeling, but in an inflamed environment, they may contribute to thinning of the fibrous cap. If that cap weakens significantly and ruptures, the body forms a clot at the site. That clot, not the gradual narrowing alone, is what can abruptly block blood flow and trigger a heart attack or stroke. The third failure involves the inner lining of the artery itself, the endothelium. Healthy endothelial cells produce nitric oxide, a signaling molecule that helps arteries relax, maintain flexibility, and resist inappropriate clot formation. Under conditions of oxidative stress, nitric oxide can be rapidly neutralized before it has a chance to exert its protective effects. Over time, this imbalance contributes to what we call endothelial dysfunction, an early and often silent stage of cardiovascular disease. When these 3 factors intersect, impaired lipid handling, structural instability, and endothelial dysfunction, plaque progression becomes more likely and complications more dangerous. This is the point in Alejandro's case where I began asking a different question. Not only how do we lower numbers, but how do we improve the environment inside the artery? And that is where an unexpected dietary factor entered the conversation. When I began looking beyond cholesterol numbers alone, I became interested in interventions that might influence oxidative stress and endothelial health directly. One food that repeatedly appeared in the scientific literature was pomegranate. Pomegranate contains a high concentration of polyphenols, particularly compounds such as punicalagins and ellagic acid. These molecules have been studied for their antioxidant properties and their potential role in supporting vascular function. In laboratory and early clinical settings, pomegranate extracts have been associated with reduced oxidative markers and improvements in endothelial responsiveness. Some small human studies have explored changes in carotid intima media thickness over time in patients consuming concentrated pomegranate preparations. While these studies are not a replacement for standard medical therapy, the findings were intriguing enough to warrant thoughtful discussion. The proposed mechanisms include reduction of oxidative stress support of nitric oxide availability and improved lipid handling within the arterial wall. I want to be very clear. No fruit replaces statins, no supplement overrides established cardiovascular treatment, but nutrition can influence the biochemical environment in which atherosclerosis develops. That environment matters. However, this is where many people unintentionally make the wrong move. A patient of mine, Isabel Martinez, 69 years old, decided to add pomegranate juice to her morning routine after hearing about its heart benefits. She purchased commercially bottled juice and drank a full glass every day. 4 months later, her fasting glucose had risen modestly, and there was no meaningful change in her vascular measurements. The issue was not the fruit itself, it was the form. Commercial pomegranate juice is often pasteurized and filtered. While this improves shelf life and taste, it can reduce the concentration of certain polyphenols. What remains is a sweet liquid that still contains natural sugars. For some individuals, especially those with insulin resistance or metabolic vulnerability, daily concentrated fructose intake can contribute to oxidative stress rather than reduce it. Whole fruit consumption is different from drinking processed juice. The fiber, the intact plant matrix, and the balance of compounds matter. In Alejandro's case, we did not simply add juice. We reviewed his overall dietary pattern, emphasized whole foods, supported metabolic health, and discussed antioxidant-rich sources as part of a broader strategy. The difference between a supportive intervention and a counterproductive one often lies in the details, and details matter when we are talking about arteries. 6 months after that Tuesday appointment, Alejandro returned for follow-up imaging. He had not stopped his statin. He had not replaced medical care with internet advice. What changed was not a pill. It was the strategy. We shifted from managing a number to influencing a process. We addressed oxidative stress through nutrition built around whole foods rather than processed convenience. We stabilized blood sugar more intentionally. We reduced inflammatory triggers. We incorporated antioxidant-rich foods in their natural form, including whole pomegranate instead of sweetened juice, and we monitored his progress carefully. The follow-up imaging did not show a miracle. It showed something more important. The rate of progression had slowed compared to previous intervals. In cardiology, slowing a disease process is meaningful. Changing trajectory is meaningful. As a physician, my personal opinion is, this cholesterol numbers matter. Medication saves lives. But cardiovascular disease is more complex than a single lab value. When we focus only on lowering LDL without addressing oxidation inflammation, endothelial health, and metabolic stability, we may miss part of the picture. That does not mean abandoning standard care. It means expanding the conversation. If you take anything from this story, let it be this question: are we treating the measurement, or are we influencing the environment that created the measurement? Now, an important disclaimer. This discussion is educational. It is not medical advice for your individual case. Do not stop, reduce, or change any prescribed medication without speaking directly to your physician. Nutritional strategies, including pomegranate or any supplement, should be discussed with your doctor, especially if you are on blood thinners, blood pressure, medication, or diabetes treatment. Alejandro's outcome reflects a coordinated, supervised approach, not a single food acting in isolation. The goal is not perfect numbers on a report. The goal is stable arteries, informed decisions, and a partnership between patient and physician that looks deeper than the surface.